A revised version of this is necessary will be sent to everyone. And those who do not have their cell phone numbers, I would really appreciate it if you would put it in here. And if you don't want it on the printed version that goes to everyone, just so indicate, and I'll just have it for myself. So let me pass this around and see. If you are okay, then just pass it along. And if not, please make changes accordingly. And while this is taking place, I had asked everyone to prepare a brief 1 to 2 minute biography of yourself to share with us, so we will know a little bit more about who we are. And so tell us about yourself, please, where you're from, college degrees, what are they in and where did you get them, family members, your present position. Are you sad or happy the Yankees just lost and aren't going to the World Series? And your experience with the issue of ethics. After that we've gone around, I will ask everyone to make a very brief presentation as to ethics in your particular discipline. So Chuck, let's start with you for the 1 to 2 minute bio.
Thank you, Mr. Chair. So good afternoon, everyone. My name is Chuck Saya, and I'm the Executive Director of the Governor's Commission on Disability. By way of background, I was born and bred in Boston. I attended Boston College and graduated in 1983. Attended Suffolk University Law School and graduated Knights in 1988. Those years are growing more and more. In 1996, my lovely wife and I, we call New Hampshire our home. We have 3 children, I have 2 grandchildren, and 2 in-laws. We currently live in Londonderry. I came to the state in 2010, took on this position at the Governor's Commission on Disability in 2013. Obviously in the private sector, a litigation background that was based predominantly in criminal defense, representing what I would refer to as an underserved population, those most in need. With that, I'm now at the Governor's Commission, and from an ethical standpoint, when this committee was formed, that I think you first ask yourself, wow, how does our commission, how does our agency deal with ethics on a regular basis? It's a broad topic, and obviously we can read the statute, we can we understand what the mission of the committee is, but how does that apply to an individual with a disability? And I'll tell you that there's ethical considerations every day that I'll get into further that we have to take into consideration. So that's my brief background, and thank you, Mr. Chair.
Yes, please.
Hi, good afternoon. My name is Anne Landry. I'm Associate Commissioner at the Department of Health and Human Services. I'm not really used to the state staff being asked for their bios. I don't know of interest, but I have a master's of business administration from the Tech School of Business at Dartmouth and undergrad from Colgate University. I've worked in education, venture capital, and healthcare, most recently, obviously. I've spent time in the healthcare system in Maine at Maine Law and Maine. I also worked for the Dartmouth Institute and DHHS prior to coming to the state in 2016. Or I'm sorry, I moved to New Hampshire in 2016. I've been with the state since 2019. And I am here on behalf of the designee for the commissioner. And while I have a little bit of experience in my business school classes, as well as working in the ethics at Maine Med and at TBI, I have a lot to learn. Just in general, how it applies here. I think one of the more difficult things is deciphering between personal ethics and you represent an organization or the state and how that works and applying your the principles towards decision making. Thank you.
And speaking of ethics, I need to let everyone know you're being recorded and transcribed.
Oh.
And I hope they will clear up a lot of this, because what they said about Tufts University in here was not nice. Trish.
Thank you so much. Hello, everyone. I am Trish Tilley. Officially on paper, that looks like Patricia Tilley. Everyone calls me Trish. I am the Director here of Public Health at the New Hampshire Department of Health and Human Services. My career started in a very different field. I have an undergraduate degree in developmental psychology from Hampshire College out in the western part of Massachusetts, and a master's in education from the University of Pennsylvania. Somehow I ended up in the field of public health, mainly because my work soon after I was out of graduate school focused on family resource centers, or family centers as we call them in Pennsylvania, and really worked to embed that both within a school district and a community, ensuring that everyone in the community from cradle to grave had access to support around them. So that's where I started. I ended up back here in beautiful New Hampshire, where I was raised, back in 2000, and have been working for the state New Hampshire Department of Health and Human Services since then. So I've got 22 years in. I started my work there really focusing on visiting programs, and then ultimately became the maternal and child health director, hot health director, and then finally I landed into this seat here. You know, I think in public health, we always balance these needs of the health of the community versus the health of an individual, always through a lens of dignity and fairness and inclusion and equity. So all of our work has ethical considerations, whether it is our infectious disease work, where this committee or this council will have some particular interest, but whether it's in maternal and child health, population health, our work in our laboratories, our work in our regulatory communities, all of that has some degree of ethics to be considered.
Proving that Hampshire College does prepare you for just about everything.
It really does. And unfortunately, I would show you, I have a round diploma from Hampshire College. That's sort of their shtick. It somehow, a poltergeist came into my office and like threw that against the floor. So it shattered. But, and as for the Yankees, I could care less about the Yankees. I'm happy the Village.
Thank you. Ben Chan, I'm the state epidemiologist at the New Hampshire Department of Health and Human Services, specifically within the Division of Public Health Services, for those who know the org structure of state government. I've actually been in this role since 2014, so it's been just over 8 years now. Before that, came from the medical field as a practicing physician. In fact, I've continued medical practice during my time here as well, sort of on the side. My role, the state epidemiologist role, I think for New Hampshire is a confusing role. Each state typically has 1 or 2 state epidemiologists as an official position, but it looks differently depending on which state you're in. And in New Hampshire, the role of state epidemiologist really is to provide not only epidemiology support, but also medical expertise to whatever work is going on that needs support. And so even though I'm an infectious disease physician by training, I end up getting involved in many other issues that are non-infectious disease related. And this has come up in a variety of instances over the years of cancer cluster investigations, PFAS, chemical drinking water contamination. So I sort of make my way into various areas of public and population health and have done so over the years. But my expertise, my passion really is as it pertains to infectious diseases. I did my medical training. So actually, at first I grew up in New Hampshire, grew up in Concord, went through the entire school system in Concord, so I'm a New Hampshire native. Love the state, love the people of New Hampshire. And so this is where I decided to come back and apply my profession. But I did go to medical school in Vermont at the University of Vermont College of Medicine. After medical training, I came back to New Hampshire and was up at Dartmouth-Hitchcock Medical Center for about 7 or 8 years, where I did internal medicine residency training. I worked for a brief period of time as a hospitalist up there, then went back and went into infectious disease fellowship, did their public health training up there at the Dartmouth Institute. A lot of trainees coming out of the Dartmouth Institute in the region, and then transitioned into full-time public health work back in 2014, as I mentioned, because I think my passion has always been more in line with public health, population health. Although, as I mentioned, I continue to stay connected to individual clinical health. So when we talk about ethics, I really approach ethics from a couple different lenses, a few different lenses, in fact, one of which is sort of the population health lens, but certainly bring also the medical individual patient lens to that perspective
We'll
as
be
well.
doing more about ethics in the second
Yes.
round.
That's right, this is only round one, thank you. That's it.
And John Williams, who has passed the bar, has also passed that bar, and you're at the big people table. Say a little bit about yourself.
Well, good afternoon. My name is John Williams. I'm the Director of Legislative Affairs for the Department of Health and Services. I'm not a member of the committee. However, I did get to work with many of you on this very important initiative this past session. So it's good to be an invited guest, or I guess I invited myself, so I'm here.
And you write beautiful music too.
I can't hum or sing or neither sound or rich, but my name is John Williams, obviously. Star Wars and
Great scores.
I was in my second term at the Health and Human Services and Elderly Affairs Committee of the House before I realized he wasn't a member of it. He just hung out there with us all the time. Yes, please.
Keep listening, and I'm a non-member, just listening in for the.
I'm Lucy Potter. I think the designee for the Bar Association. New Hampshire Bar Association, and I am, right now a professor of health law and policy at the Franklin Pierce UNH School of Law. And I also am the director of health law at the Institute for Health Policy and Practice. And, my background is really sort of long and boring, but anyway, I grew up outside Boston, went to Princeton University, and then Georgetown University Law Center, graduated in 1990. And then practiced and came here in 93 because my husband was doing his medical training up at Hitchcock in California. And worked at the Attorney General's office and the Civil Bureau, representing DHHS and all you folks for a long time. Then went to Rathyoung and Pignatelli and was the chair of the healthcare practice at Rathyoung and Pignatelli as a partner a long time, until I went to serve as Governor Maggie Hassan's legal counsel and chief health policy advisor during the implementation of the ACA and all kinds of other things. Then went to the law school in 2015-ish, a little later, and have been working mostly on teaching healthcare, health regulation, and throughout my practice, I've really focused on privacy, fraud, abuse, and now a lot on equitable access to affordable healthcare.
Senator.
I am Ruth Ward. I am appointed by the Senate, then the Senate President, to be on this committee. My background is lengthy, but I'll just make it very short. I'm a legal immigrant at this point. I was born in China, spent my teens in Sweden, came over here to the United States as an exchange student. And I worked at the Children's Hospital at the Cardiac Catheterization Lab in Boston. I met my husband, we got married, we had 3 children. When the children got to be sort of old enough, then I decided to go back to school. So I went to nursing school and worked for a while. And then I decided I didn't know enough, so I went to graduate school. So I have a master's in gerontological nursing and nurse practitioner from VU. I also had, when I was working, I had certification as a diabetes management instructor. So I've done a lot of different things in healthcare. Then when I moved to New Hampshire, I became active in my local town. Been a planning board member and the ZBA board member. And I'm trying to figure out all kinds of big things. But right now I am a state senator and it keeps my hands full with work to do.
Thank you. Professor.
Thank you very much. My name is Mark Rugani. I'm assistant professor of theology at St. Anselm College in Manchester, Goffstown, Bedford, and where everything comes together. I've been at the school since 2019, having just completed my PhD at the Catholic University of America in Washington, DC. I did studies as well, my master's degree at University of Notre Dame and my BA at Georgetown University in Washington, DC. So spent many years in Washington in academic preparation. Originally from Buffalo, New York. I found New Hampshire to be very warm and welcoming and also the kind of cold that I like.
Go Bills.
Go Bills, right?
That's right.
My current role at St. Anselm College is mostly serving our nursing department, which is transitioning to become its own school of nursing, under which we're going to have expanded facilities for training for laboratory space, and we're also starting a new public health major and minor. I'll be serving those different majors, making medical ethics is a required course for our students in those programs. And I'll get more into my understanding of ethics and how that interfaces with, I think, our role here in service to the public. But my training at the Catholic University of America was intentionally both moral theology, understanding the value orientations of particular religious communities and a sensitivity to that and other religious commitments and those who are non-religious. And the training also engages with secular ethics. And so when I'm teaching medical ethics to my students, the goal is what we call tradition-constituted inquiry, to really work across lines of kind of commitment and understanding so that we have a language to understand the coherence of different people's views, their arguments and rationality, and to appreciate the reasons why we can move from particular principles to different conclusions and still have sound arguments.
Thank you. Welcome. Representative.
Hello, everybody. Good to see you. I'm Alexis Simpson. I live in Exeter. I represent a kind of flotarial district, circle around there, but which is Exeter, Stratham, Fields, and Newmarket. This is my second term in office. I was back in 2015 and 2016 in the Environment and Agriculture Committee. So real quickly, that's actually my I would say hobby that became a passion, and how I came into politics was through sustainable agriculture policy. But my profession is as a minister. So I did my undergraduate. I have a BS in physics from the University of Virginia. So I brought that to my Master of Divinity in Atlanta at Emory University. So I did that early on in my career and pastored churches, and then also in an academic setting. And then for a while, spent time raising my kids almost full time, and also working on the agriculture policy end. And then came back and am now ordained in the United Church of Christ. And so I serve churches there, and I'm now a volunteer chaplain again in an academic setting, which is wonderful. And I did, I guess, a few years ago, I went back for a Master of Theology, which was like a 1-year degree to do after your Master of Divinity, and I focused on religion, ethics, and politics at Harvard Divinity School. So I think that's partly why I'm at the table today. I have my specialization is on interfaith community building, and that's particularly in academic settings, but obviously has a lot of relevance in just our everyday communities in which I operate as a state representative. I think that's probably all you need to know about me. I like baseball. I'm not a fan of the Phillies, but I had so much joy last night watching them celebrate that it was wonderful.
They did have a good time.
Yes.
Yeah, they had such a great time.
Well, hi, everyone. My name is Celia Oliver, and I'm a psychologist, and I grew up and had most of my training in Ohio. And I've been in New Hampshire for just over 25 years. In terms of training, I have a PhD from Miami University of Ohio in what back then was called physiological psychology and is now called neuroscience, and taught and did research in that area for about 10 or 12 years. Then realized, oh, this isn't as much fun as it used to be because I'm having to fight harder and harder for the research dollars. Nobody wants to collaborate anymore. And I realized most of my friends were clinical psychologists. And so I was teaching adjunct at one of the local universities and said, yeah, I'll go back and get a PsyD. So I got a second doctorate in clinical psych, and proceeded to do that for about 25 years. I recently closed my full-time private practice in Peterborough. I specialized in treating anxiety disorders and autism spectrum disorders, and I saw kids, families, and adults. I closed my practice because my mom's Alzheimer's was getting much more advanced and she couldn't travel anymore. And I knew I wanted to have freedom to travel back and forth. And I knew that ethically I could not hold a whole practice and do what I felt I needed to do for my family. So I go back to Ohio often. And I still maintain a very active professional presence in New Hampshire. by being quite active in the New Hampshire Psych Association. And that's primarily the way that I came to you all. At the you all is the Nervous Ohio thing. So if I was in Kentucky, it would be y'all, but it's you all in Central Ohio, right? So in terms of NHPA, I've been the chair of the Ethics Committee for about 15 years. And part of what we do there is that we rotate, each of us being on call, and any member, any psychologist or other member of NHPA who has an ethical dilemma, they can call us. We will call them back. We will help them think it through in terms of the clinical issues, the ethics, et cetera. I'll go into that a little bit more later. And then we also do these roundtables in terms of continuing education credits for any small group of therapists who want to bring us in, and we tailor that those topics specifically for that group. I'm also on the executive committee for NHPA and have been, currently my role is, I'm just thinking past president. And and I'm co-liaison to the Board of Psychologists in terms of our licensing board. So it gives me a breadth of experiences to bring in terms of the ethics. That's it for now. Thank you.
Are you representing someone?
I am the IT person.
You are the most. I'm one of liberal arts people. I'm Mark Pearson. I have served 3 terms in the House of Representatives, all of which are on Health and Human Services, the last 2 years as chair of it. In addition, I'm chairman of the New Hampshire Commission for the Deaf and Hard of Hearing, which you're on as well.
I am, yes.
And I also serve as the chairman for the Joint Legislative DHHS Oversight Committee. I was born in Leominster, Massachusetts, where plastics was invented, and a diehard Red Sox fan. When it comes to the playoffs, that usually means ABY, anybody but Yankees, is whom I'm rooting for. I'm married to a family practice physician, and I serve very much part-time as executive director of that facility in Kingston, where we combine medicine, family practice medicine, counseling, massage, community, and patient education in a faith-based practice where we offer prayer to our clients and patients with, of course, their right to say yes or no. Academically, I went to Williams, and then it happened that Oxford said if I went there, they'd pay for it, and who am I to turn Oxford down when they want to pick up the tab? My master's was in theology. One of my study partners was the great theologian N.T. Wright. The other one was Oliver O'Donovan, who quickly became professor of ethics at Edinburgh. So came back to this country, was still too young to be ordained. I went to Virginia Seminary as organist for a year. Was ordained in the Episcopal Church 47 years ago, and we have a small church in Kingston. I have 3 children. One of them, the eldest, is Stephen, Representative Stephen Pearson, who serves on eDNA out of Derry. For many years, my full-time, or part of my work was doing teaching conferences in churches, sort of mainline denomination version of revival meetings. I also served as an adjunct professor for 16 years of theology and church history, and very much miss the classroom setting. Oh, that's the bios. And now if we could start again, go around. Having done not so much a deep, but a somewhat deep dive into the different disciplines of ethics, depending on what the discipline is, was starting to work on a Venn diagram and figured you guys could really improve that, because ethics from all of us will have many things in common. In fact, the reason this committee was established is the previous committee was made up of some very good people, but most of whom had no training in ethics. And it wound up being very much looking at an issue from an economic or a political stand, and that's valid. But the commissioner wanted people who, to various degrees, had training in ethics. So with that.
Sure, well, thank you again, Mr. Chair. So again, I'm the Executive Director of the Governance Commission on Disability. Very high level, it is an executive branch state agency right within the organizational structure of the governor's office. So when you look at the GCD, you have to look at the backdrop of the Americans with Disabilities Act. So the ADA, from our perspective, and really across the country, was a game changer for individuals with a disability. Because essentially in 1990, and it's a federal piece of legislation that's 32 years old, it basically said that any discrimination based upon disability cannot exist. So I look at it, and as many do in my office and across the country, as a game changer. Because, you know, for years, there were individuals with disabilities who are not able to access the same services, the same programs that everyone else in society were able to access. So from that vantage point, when we look at ethics, I mean, even though we can refer to the ADA as a civil rights law, I mean, it was really based in ethics. It comes down to what, you know, doing the right thing. I mean, at the end of the day, isn't that what this is all about? I know we've heard, you know, the statements, you know, what's integrity? Well, that's doing the right thing when no one's looking, and it's true. I mean, from a personal level, that's been something that's been in my life all along. So again, we're the GCD, as we refer to our agency as, we're not an enforcement agency, we're not an investigatory agency. But it's all about education and awareness and raising the awareness of the Americans with Disabilities Act and looking at all disabilities across the spectrum. So yes, Representative Pearson had referenced statutorily appointed to the Commission on Deafness and Hearing Loss. I sit on other appointments, again, within that realm of disability. So it's looking at the broad spectrum of programs and services, because that's what we're charged with, to advise the governor, the legislature, on policies that may affect individuals with disabilities. So I would suggest that the term ethics, and we can Google it and we can look it up. What is ethics? Well, you know, there are certain things that we all know are just inherent in the discussion about ethics. And I think from the position of the ADA and from the position of an individual with a disability, it's ensuring that there's full inclusion into society. It's ensuring that that individual, again, is not suffering. And again, we use these terms. I may use terms even to this day that are incorrect. I use the term suffering. Well, we want to eradicate stigma. Stigma is a big part of what an individual with a disability may have. We see that within the mental health field. And that's a barrier that has to be broken down. Although there are terms that we use, we break down barriers, we want full inclusion, that there really is that undercurrent of ethical considerations, you know, when we look at an individual. For purposes of this group, you know, let's look at there are many definitions of disability. So security has its own definition. The ADA has its own definition. So to be protected by the ADA, quoting from the ADA, one must have a disability which is defined as a physical or mental impairment that substantially limits one or more major life activities. A person who has a history or record of such impairment, or a person who is perceived by others as having such impairment. To me, that's a very beneficial definition, especially within the framework of ethics, because we're not really pigeonholed and saying that we check off boxes. We're looking at the breadth of a federal legislation that really is geared toward that full inclusion. So under the ADA, we have an obligation not to discriminate against an individual with a disability. The ADA affects all walks of life. I mean, there are 5 titles under the ADA. I won't get into it. Title I deals with employment to ensure that employer and employee enter into those relationships from an ethical standpoint of what one can do and can't do. We hear about accommodations in the workplace. Title II deals with state and local government and what can the government do to ensure that there's non-discriminatory actions. Again, what I view as ethical considerations at the end of the day. And Title III deals with basic physical access to a building. Should there be a ramp? Should there not be a ramp? Do we need elevators? What do we need to ensure that full inclusion? Again, I go back to how I started this, it really comes down to doing the right thing, although, we're involved with many, I'll end this in a bit with a call that came in today. That is, in my opinion, spot on. But it's one thing to read the letter of the law, and we all know that. We know what standards are, we know what procedures are, we know what we have to do. But at what point do we go above and beyond? At what point do we just say, well, should we do this? Okay, so again, bad example, maybe the ramp isn't required under the law. But maybe the right thing is to put the ramp in, or to provide the program or the service. So the ADA is going to affect the medical field. It's going to affect workplace employer regulations, business policies, and attendant with all of that, there are the ethical considerations that I would say are just part of that discussion. What's the fruit of the ADA? I mean, obviously, we've come a long way in 32 years. Can we do better? Absolutely. Are there more ethical considerations for individuals with disabilities? Absolutely. But we're moving in the right direction. Is the ADA perfect? It's not perfect, but again, we're all on the same path here, toward what we want to ensure that that an individual with a disability has that full inclusion. We refer to it as a universality, access for all. And it starts with the lives of individuals to remove those obstacles that person may see in a medical setting, may see in a workplace setting, may see when they want to go to the corner store or just to enter the building. Within disability itself, from an ethical consideration, and again, with some research we've done, there are other considerations, within the medical field, and again, I don't have that background. I know many people have that. How do you view a disability? Is it viewed from a vantage point of something that should be fixed or something that should be attended to? And I guess there's an argument for that of course there are certain things, if we look at a temporary disability, if someone breaks their leg, that's a temporary disability. What are the ethical considerations? But then there is another school of thought that looks at it from the social end and looking at the diversity that person brings in and really celebrating that disability. So, from my legal background, as for the other lawyers in the room, we're trained a certain way with professional standards and ethics, and we look at ethics within legal. Within the Governance Commission on Disability, which is really a boots on the ground type of agency, we're dealing with what the mom is dealing with because her child can't get into school, or because an education plan isn't in place, or because someone can't access a building because of inaccessibility. Those are the ethical considerations that we're looking at on a regular basis. So with that, it's a breadth, it's an incredible definition. I will tell you, when I was first named to it and put it on the table, it can be daunting, and it's important for all of us to come together and obviously address the issues. I did say I would end on a story. This story came in today, so I get this very, very lengthy email. It's not going to be spot on in this committee, but you're going to see the analogy. So very lengthy email. A mother has a child with significant disabilities. And she is attempting to put a ramp in her own home. So she went through the process. She pulled the building permit. And the building permit was denied because it didn't meet the setback requirements. Okay, this is a woman that wants to put a ramp into her own building. So the town hall basically told her, you have to go through the process, go through the ZBA and apply for the appeal. Well, that hearing is coming up and they said, no matter which way this turns, assuming it's in the affirmative that they overturn it, you're still gonna wait 30 days. So the woman is reaching out. She's reached out to the federal delegation. She's reaching out to state representatives, and she's reaching out to GCD. And I had a great conversation, and I explained what I'm willing to do, what I'll try to do. And she went to other organizations, and they said, well, no one's really broken the law yet. And that's true. There isn't the law hasn't been broken. But then the woman turned to me and I thought it was incredible. She was, yeah, but Chuck, isn't there something ethically wrong with this situation? Those were her words to me today. And I said, I get it. And this is what we will attempt to work with. So, you know, I'm just trying to give you a flavor of, from my perspective, with dealing with individuals with disabilities and full inclusion. Sometimes you have to peel it all back and say, what are we gonna do to get that person into what they need? Sometimes that was the overarching, ethical consideration.
Thank you, Chuck.
Yeah, I'm
And-
sorry I was long-winded. I
No,
can't
that's a
be,
good story.
well.
And I have a gavel, but thank you.
Okay, yeah, and I do want to say thank you, because obviously, certain individuals, we don't even have to, I mean, I've seen Dr. Chan, and I automatically assume he knows me, but he doesn't. But we saw you for so many, you know, for daily debriefings, but I say that to all of you in the room, and I say this from the bottom of my heart. It is an honor to be here, and I look forward to the future meetings. Thank you.
Thank you.
Thank you. I would just echo that I am also honored to be part of this group, and listening to everyone's backgrounds would further reiterate that I am just scratching the surface in ethical training, ethics training. However, I would just say, you know, personally, all of my work is like and driven by the right to have the right to advocate for those who need, you know, who are most vulnerable and need people to advocate for them, and governed by a moral compass, and the right, my wishes to do the right thing always. I really think about our work at the department, and it's our job to take care of everyone across the state, regardless of who they are, where they're from, what their needs are, whether it's from a vulnerable population or not. And really understanding how to meet those needs, I think, is also part of ethical decisions, and knowing when you don't have that insight, you know what that person needs, that you surround yourself with people who are experts in that, and understanding the difference between equity and equality, and holding yourselves accountable to meet those needs of individuals, as well as ensuring that there's integrity in the practice and operations of everything. I think about it as, if I look at my areas of Medicaid, public health, and health equity, it's everything we do is about figuring out, knocking down the barriers, like you were talking about, Chuck, to understand what's the right thing to do. Here's the rules, but that's not working for this family. They need this. And I think it's also helping others put aside their personal beliefs, often of what's personally driving them to make certain decisions, to know what's best for this population, these people. And whether we're working with the legislation, whether we're working with the MCOs or anyone in the community, it's really understanding what they need and how we can best support them, regardless of our personal. There is a quote that I like to live by, which is that the only guide to a man's conscience, the only shield to his memory, is the rectitude and sincerity of his actions. Just Winston Churchill, and I find myself always wanting to say that in my head, like, what is the right thing to do? I have to follow our moral compass and the true north, and going. With that being said, I have a ton to learn from you who are backgrounds or systems in this work, and forward to that.
Thank you.
And also bringing it back to, of course, the Department of Health and Human Services and our leadership as well.
Trish.
Thank you. So my work is why we're all gathered. So when I think about this committee and this advisory committee is designed in statute to offer, you know, the commissioner, the department, the Division of Public Health, the guidance that we need with relative to ethical issues that may be identified in the course of planning for, responding to outbreaks of communicable disease that threaten our communities. That's sort of at a very high level, but what I'm really looking forward to is not only that letter of the law, but really the spirit of that law as well. And I think that it impacts all of our work. You know, in public health, we have an ethical responsibility to close disparities, to close gaps in health outcomes, and specifically with regard to individuals that may have experienced racial injustice in their past. People because of their age, people because of their disability, as you so beautifully described, as well as a number of social drivers of health. That's really the root and the bottom of all the work that we do. You know, we think about every day, as I mentioned when I introduced myself, the health of the community and the health of an individual. In perfect times, those perfectly align. There are times, however, we come up against rough edges. And so that's what I'm really looking forward to, the academic preparation of the people in this room and your lived experience to help us think through that, not just within the lens of a Department of Health and Human Services and the Department of Health in particular, who is looking at a specific outbreak or a condition or a really thorny problem. And how do we navigate through that? And so what I hope that we do as a group together here is really center that thinking around the voice of the community that's impacted, whatever that community is, really with a lens of social justice, and always guided by some beneficence in some way that we are working towards some public good at the end of the day. I have no doubt, I mean, all of our work, and certainly the 3 years of work that Dr. Chan has helped lead us with through the pandemic, is we've come against thorny bits and rough edges and places where honest and ethical people have disagreements. And so I look to this group to really help us navigate that as we try to implement health policy.
So I'll probably echo a lot of what Trish just said, but maybe I'll start with my last sentence from round one, where I said we really approach, we look at ethical issues from two different perspectives. One is the individual medical perspective, the other is the population level perspective. And you know, I think looking back over the course of my training and occupation, and I can't think to a time where I ever had a specific course in medical ethics, for example, in medical school, or a specific population health ethics course, getting a master's of public health. But I think ethics and ethical principles have been woven all throughout the training and education. So for example, as a medical provider, as a physician working in a hospital, you run up against, individual medical questions and medical issues all the time. And there are oftentimes ethical consults. There's an ethics committee you can consult, a medical ethics group that can come in and weigh in on specific thorny issues or circumstances. And so I think as a physician, as a healthcare provider, and through training, through work experience, we're constantly exposed and experiencing ethical issues, balancing the rights of, patient care as one example. And so, frequently we will care for patients who decline recommended medical treatment. And we allow that person to decline medical treatment, but we still care for them, right? And so that's one example of, individual medical issues that come up. On the population health side of things, right, we frequently encounter ethical questions of a different form. Health equity, making sure that disparities and determinants of health are addressed to try and narrow the equity gaps that are there in the population. But I think one way I look at this is that usually what's good for the individual is good for population health at a community level. What's good for population health or improving population health usually leads to good individual medical care. And so when we're talking about Venn diagrams, really they're overlapping diagrams, right? Oftentimes the medical system is delivering population health interventions. Population health interventions are contributing to individual medical care. So there tends to be a lot of overlap between medical care and population health, and the same applies when you talk about ethics, right? Ethical treatment of individuals, and population health, but there are ethical issues that are encountered in both, and I would maybe classify these. When it comes to a prominence, I would sort of classify these in two different categories, based on what we've experienced over the last few years in particular. One is balancing the right of the individual with the, community population health. There is tension there, as Trish just mentioned, echoing what she said. The other thing I wanted to bring up, though, is that frequently some of the toughest decisions are when we encounter scarce resources, right? And so we're left having to decide who gets upfront scarce resources. And one of the best examples of this is the rollout of the COVID-19 vaccines, when we had a whole group that was formed here trying to come up with a plan for vaccine allocation based on medical ethical principles. And these are always tough circumstances, and there's many people weighing in, and the plans change, and people have different opinions. And in that circumstance, a group like this would have been, I think, incredibly helpful, incredibly beneficial for helping to cement that plan that was enacted. And there's different groups weighing in on these issues from different perspectives, politics, from medical, perspective, and frequently there's not agreement, right? And so that's where a group like this together can be very helpful. But I think my basic comments are meant to, I think, get to the point that there's the individual health, there's the population health, and frequently, usually, good individual health leads to good population health, and vice versa. But oftentimes there can be tension between those when people decline good medical recommendations or good population health recommendations, and that's oftentimes where some of the ethical questions arise. In addition to the situation of allocation of scarce resources, which falls a little bit outside of that Venn diagram. Thanks.
Thank you.
It's kind of fun to talk about our ethics. I'm a lawyer, so maybe I should say no more. So
This is my voir dire, by the way.
but yes, worked with professional responsibilities in ethics, all of my career, and in healthcare, really managing the regulatory side of balancing the individual ethics, and professional ethics, everything from privacy, consent, and fraud, which is really when, professional judgment gets clouded by influence, money, politics, you name it. Just professional decision-making, and then access and equity and all the ways fairness comes to play when you're balancing individuals and community outcomes and ethical decision-making. So do the right thing is easier said than done. But I think I was with a number of you on March 5th, or the end of February, on the state crisis standards of care committees. And then I was appointed to the SDMAC, where we were trying to manage and figure out crisis standards of care and the ethics involved in that throughout the pandemic. So, I bring that history to play and hope I can be helpful.
Thank you so much. Senator.
So as a nurse, I certainly had maybe not specific classes in ethics, but it was sort of through everything that we did. You treat the patients with respect, you listen to them, you treat them as a person. You may not like how they look or what they have to wear, but you have to look beyond and see who is this person really, and go beyond the outside manifestations. You don't do something to the patient without their consent. You don't hit them with a treatment that they know nothing about, which really means that you need to sit down and you talk to them, you explain, and if they have any kinds of concerns, then you just have to work a little harder to help them to come to their decision. But I think at the end, you have to respect their decision. They are autonomous. You cannot force somebody to do something that they do not want. And I think you have a responsibility to explain what the consequences might be. The thing that Ben just mentioned about the difference between an individual's right and the right of the whole population. That's, you know, that is tricky because you can have one person who can be very ill, doing something terrible that's going to affect the whole population. And where do you draw the line? Where do you regulate that person so that the population is not harmed? And I think that's a tough issue, and I think sometimes that's gonna take a lot of thinking, a lot of delving into what's really going on and what are the benefits and what are the bad things that might happen if you let it go. So that's sort of where I'm coming from, and certainly as a senator, we have reviews of ethics. We get a little booklet of ethics. It's just, it's constantly there because we make decisions that we really have to think about. What is this decision? What does it mean?
Professor.
Senator and everyone who shared already. Ethics is my profession. So I'm coming in kind of perhaps at a high theoretical level. But my interests are really applying that theory and making sure that it doesn't just stay in the ivory tower. I see myself as a public servant as much as I can help here, and also in the education that I provide to my students. And my background is really in social ethics. And so coming here today, and thinking about the balancing of the individual and population, as Dr. Chan said, I see them as interwoven and interdependent. Would like to echo that a lot of what I do in teaching clinical nursing ethics is also very important to understand what's happening at the policy level. So that micro interacts with the macro. And there's also a meso level that I don't think often gets talked about with what happens in particular institutions like hospitals and clinics, and how they interface between the policy and the personal ethics really needs to be parsed. So we continue to kind of explore how the different structures that we've created, whether it be by legislation, through culture, affect the kinds of access that happens. And as a Catholic ethicist, one of the parts that informs our social tradition is a preferential option for the poor and vulnerable. And so when I come into rooms and kind of try to see who's at the table, I'm always thinking about who's not at the table, who doesn't have a voice, and be able to add their kind of right to speak to the consensus that's being discussed. And sometimes religion is one of those institutions that can limit participation. But it's with the, I think, an appropriate interpretation of the doctrine that I ascribe to as a confessional Catholic theologian, that we really try to be as inclusive in bringing everybody to the table, because that's consonant with the first principle of Catholic social teaching, which is dignity of the human person. It's the first and foremost principle. It recognizes persons as ends in themselves, and that autonomy is recognized within them. And also, kind of my background, see people created a religion like this of God, which looks at things that are obligatory, but also I think helps us to move beyond what's obligatory to the supererogate, and how we can be morally courageous, not just in our personal interactions, but also in our policies. It's something that helps us to create a new culture in communities that is greater, gives greater access to those perhaps with identified disabilities, or those who might not have, as I said, kind of access permanent addresses, mental health stigmas. And so moving from dignity, it's always aimed at the common good, and a really full understanding that it's not just a purely utilitarian, majoritarian, greatest good for the greatest number, but it's something that has to account for how do we help create a facility for each and every member of a community to flourish. And so we do that in Catholic social teaching through two different aspects. And I think it echoes a lot of kind of this kind of reciprocal understanding of solidarity in understanding the responsibilities that we have to each other, that our individual goods are inextricably tied up with the good of each and every other person. And also subsidiarity, which is the understanding we want to empower persons to make autonomous choices, informed autonomous choices. But when they lack the resources or the facility or the standing to do so, we provide aid from higher levels that do have either authority or access and power to really help advocate for that. And so these are kind of the four principles that inform my approach, and I really find them to be consonant with much of the ethical principlism that informs professional codes of ethics in medicine. We see beneficence, non-maleficence, justice, and respect for the dignity of a person as autonomous. And I find that that is something that's really kind of consonant with that. And so whenever kind of looking at this, I try to be as circumspect as possible, really recognize all the voices at the table, and try to find ways that we can speak perhaps across boundaries of language, of theoretical constructs and frameworks in order to, at least if we can't come to an understanding, to find ways that there might be enough overlap and consensus from our traditions to be able to create things that are for the public good and to really advance health and the services available to our communities as a whole. I do this for 75 minutes a day. I could go on, but I invite, any questions and correspondence at any point. This is, like, as I said, I do this for a living. It's become a passion in light of experiences that I've had with direct relief services that I've done internationally and working with populations even here within the United States and helping to create access.
Should we assume this is going to be on the test? Thank you. That's the correct answer. Representative.
Just keeping track of the words that we define.
There you go.
Right. That should be a little section of the notes. Right? A little section. Gosh, I'm not sure that I have a lot to add. I feel like we've covered a lot of the overlapping pieces of the Venn diagram at all. I'll just share one of the things I was thinking about before I came in here was just the difference between morality and ethics, and that's just kind of really important for us to probably talk about and define, to just recognize that our morality is kind of what the folks around us think is good, and then our responsibility in ethical reflection is then to step back and critically reflect on whether or not it is good, right? And so to have those deeper conversations that reflect critically on what's coming to the table. I think the situation you described, Dr. Chan, about how so many different voices and opinions come into the conversation, and how do you pick apart and pull apart and find what's ethically good in the midst of all of that. So I was thinking about that a bit, and then also thinking about how in my religious tradition and in other religious traditions, part of that is for all of our goals kind of as individuals and to parse out, like, making sure our own, like, ego and pride and desire for wealth or status or power are also kind of separated out from that deeper wisdom that we're trying to get at in terms of our ethical decision making. And then my own experience, I laugh when the internet was young and I was in an academic setting of teaching freshmen in college the ethics of email. And just but it was that, but it was also like, how do we behave with each other in really healthy and holistic ways, and then in terms of practice, most ministers are trained in a clinical setting in a hospital or something like that, where we have the opportunity to engage in those really tricky and difficult situations that arise practically. And then there's one more thing. Oh, yeah. And so my profession is just to also have a commitment and an obligation to work with people in other professional settings in order to serve both individuals and communities at large. So it's nice to have the opportunity to do that with all of you.
Dr. Hall?
Wow, what an impressive group of people. I just kind of want to hang out with you all in this chat. There's so many interesting aspects. So let's see, for us as psychologists, it's the American Psychological Association who writes our, it's technically called the Ethical Principles of Psychologists and Code of Conduct. And essentially, it's divided up into two sections. There's the general principles, and those are actually aspirational. Their intent is to guide and inspire psychologists to uphold the highest standard of ethical care. The ethics codes are the specific standards that we're to adhere to, and they're intended to cover most situations for most psychologists. And psychologists are actually, there's a wide range of roles that psychologists can take. It's not just doing therapy and clinical psychology. It can also be being a diagnostician, being a researcher, educator, supervisor, consultant, administrator, social interventionist even, and expert witness. And so there are many ways that psychologists intervene at an individual and community level, potentially. I thought you might find it interesting to hear what our 5 principles are. And they are, first of all, common to, it sounds like all of you who have spoken, beneficence and non-malevolence. So I won't explain those. Fidelity and responsibility is our second principle. And that means that we establish trust with anyone with whom we work, and that we uphold professional standards of conduct. We clarify our roles. We cooperate and seek out cooperation and consultation with other professionals. And we do our best to work collaboratively with anyone we work. The third one is integrity, that we promote accuracy, honesty, and truthfulness in the science and teaching and in the practice of psychology. The fourth one is justice, and that's that we recognize that fairness and justice entitles all persons to access and benefit from the contributions of psychology. And then the fifth one is respect for people's rights and dignity. Again, something I've heard various forms of from each of you, and that's that that all people have a right to and are worthy of dignity, and the rights of individuals to privacy and confidentiality, as well as self-determination. So the code of conduct, that part, the very first one is actually resolving ethical issues. And it has to do with what happens is if you as a psychologist are aware of another professional, especially if it's another psychologist, doing something that, yeah, that's not really a good idea, then there's certain steps that we're trained to take, that you do that informal resolution first. You approach your colleague and say, I'm really concerned about XYZ. One of the ones that comes up fairly often, since I'm an aging psychologist myself, is what happens when this colleague of yours, who has been brilliant for so many decades, is showing up late and doesn't seem to remember who their clients are, but they don't see a problem. That's an issue. So how do you handle those kinds of things? Second code for us is competence. We have codes around human relations and making sure that we don't have multiple relationships with our clients. That can be really tricky in rural New Hampshire. So there's also codes that pertain specifically to those who have a non-practice form of psychology in terms of teaching or doing research, and how to treat your subjects or animal welfare if you're working with animals. All of that is covered by APA. And there are so many dilemmas that come up constantly. And so doing the right thing is the most desirable part. And yet sometimes it's not that easy to figure out, because there are multiple right things, and right thing A might go differently from what right thing B would advise. So we have various frameworks trying to think through those ethical dilemmas and ways to come up with a decision. So that's it for me.
Thank you. Well, one of the things that's been very important to me in teaching theology over the years was to try to step back from the present and see the grand sweep. And not only in terms of what did people facing similar issues understand in other times, but how about in other cultures? When I was writing one of my books, I told my wife of the diversity of people I had consulted. She said, yes, there's quite a diversity within the universe of old white Church of England men. I said, well, you can get quite a diversity there. She encouraged me to stretch it. And I did, not only looking back in history, but intentionally reading Asian and African Christian theologians and then widening the circle from that. And it was very, very enriching. And it is something that I now much more try to do than I did before. A couple of practical things where I try to think ethically in the House of Representatives. You may know that there was a bill brought forward that would change the allocation of organs. And I thought it was unethical. So I worked very hard, and you can see from this little pin, worked with the folks outside of Boston who, and I'm blanking their name, but who have studied the issue of allocation of organs from an ethical perspective and brought that in and got the bill killed. But it was quite an ethical education along the way to see how do we apply, who do we seek out to inform us, and is it just me and this is what I want, or this is, I got the political votes, or are there some objective standards that most reasonable people should adhere to? The second thing, being a chairman of Health and Human Services, I lost count how many bills we had before committee on COVID, on vaccines, and noticing that within, I suppose if you have 400 representatives, you're going to get a sampling of just about everything that exists. But at the extremes were people who are saying, this is the best practice, science has spoken once and for all, and you will do this or we will make you. I heard that more than once. On the other hand, I heard I don't care what you think, we should have stopped right there, but nobody will tell me what to do. I have my rights. And, you know, try to be the adult in the room where both of these extremes are raging. It was quite a 2-year term. I think the one that I really did a lot of ethical thinking on was House Bill 103, the dental care for Medicaid. And we had 24 years of that not passing, irrespective of which party ran the show. And I saw this as a clash of virtues possibility here. Andrew Carnegie suggested, how do you do good without doing harm at the same time? And handouts can be wonderful when people really have a need, but they can also be a trap because sometimes they can keep people dependent. It can dehumanize. Yeah, right now, maybe others need to help you, but can we do this with the understanding of trying to empower you so that maybe there will be a time when you don't truly need what we're providing? We want to give you dignity, maybe first with something concrete, but all the way through with dignity. On the other hand, the old sucks to be you is also ethically wrong, where we walk away from people because we don't care. And what do? And this is a group of people in my constituency who are too rich to get government help, but they're too poor to make ends meet. And there is a section in one of my towns that has a lot of those folks. And I can understand why they're angry that some people are getting help when they're not. And they're having to work extra shifts and they're having to say no to various things their kid wants because they don't just have enough. So what I tried to come up with, as I said, we're going to have to amend this if this is going to get through, is some ways to require folks we're trying to help to pull their share, even if it's just a little. We're not asking you to do what you cannot do, but we will be asking you to do what you can. And that will speak to others who thinks it's unfair. It will also speak to the issue of we don't want to keep you dependent so we can go home at night and feel good about ourselves for giving away money to people, but we really, truly, genuinely care and want to help. So all of that was rolling around in my mind as I finally concluded that this bill isn't going to pass unless I take point on the House floor. The Democrat sponsor of HB 101 did a wonderful job, especially when I amended this bill. But somebody has got to walk it through, and as you know, it passed. And so for me, that wasn't just, how do I get this thing done politically? But what should I get done ethically? And I'm not saying it was perfect, but I'm saying it really was for me, what I hope will be my model of how I proceed going forward. So that's my story. And I'm hoping that all these wonderful talk to text lines after some very strange typing has been cleaned up, could be made available to all of us. And we will be in touch when we get cranked up next. So thank you, everybody. Anybody have any last words they want to say?
I would just like to thank everyone for coming in today, into Concord to have these discussions. We're very much looking forward to having all of the input that is around this table and hearing those voices. I think it's going to be incredibly beneficial to, so thank you.
Yes, please.
What are you thinking about our trajectory?
Would you clarify?
Well, how often might we be meeting? What are we? Do you have any?
My original thought is as needed, as the commissioner or someone at DHS says, I've got an ethical issue, get the band back together. Or as one or more of us sees an ethical issue that we might like to weigh in with the department before they ask. But the idea of meeting every month, I hadn't seen on my radar. After you've gone home and thought about it, this was so good that maybe we might want to meet once a quarter, just and have an ethical issue to chew on as a kind of senior common room here. Sorry, faculty lunch, wrong kind. And so think about that, I'd be happy to do this. This was.
And I think from public health, we would also be happy to provide information about what we do in some of those areas that might be helpful. I know some of us have worked together a long time, and then there are others that are new to the thoughts around public health that might be helpful to have some of that background before there is something that we really need to jump into. So I'm happy to do that as desired by the chair.
Wonderful. Let's keep in touch. Good, thank you.
Thank you. Thank you.
I like it.
Thank you. Way back there.